Right, morning everyone, and welcome to this special event that we're able to put on. First, I want to thank some staff in public health in Derbyshire County Council for making this event possible. So, particularly thank you to Rosie Brown, who works for public health in the High Peak area and has been instrumental in linking with Professor Hall in making this happen. Thanks to Joe Hall for supporting this event, and Helen Denness, and also thanks to Jackie Roddis at Derbyshire County Council for supporting with the technology. That, fingers crossed, this all works and goes to plan, and the Wi-Fi doesn't drop out. If for any reason there's an issue with my Wi-Fi, then Helen will pop up and take over as a sort of host of the session. But anyway, I'm a little bit starstruck today. So we've got Professor Donna Hall with us, so described as a public service pioneer by the Mayor of Greater Manchester, Andy Burdham. Awarded a CBE in 2009 for innovation in public services, and well known for her work in Wigan for over 8 years, the Wigan Deal, and something that's been a real inspiration to us in Derbyshire as we try to look at how we work with communities and build capacity in communities rather than doing two and just being a mere provider of services. So it's a real honour to have Professor Donna Hall with us today. So welcome, Donna.
Hi, Dean. Thank you very much. That's very nice, kind thing for me to say at the beginning. Thank you. And I'm just really impressed with your choice of music. Can't beat a bit of Bob.
Excellent. And for us in Derby and Derbyshire, we'd love to hear more about the story of your time at Wigan and the things that you achieved during that time. So firstly, what did you do and how did you start doing it?
Okay. I'm just going to be really honest with you, because I think, it's pointless not being honest. It wasn't easy. It was really, really hard. And it also wasn't, which I know you will be finding as well in Derbyshire. I'm really impressed with your vision for Joined Up Care. So it started back in 2011, and there were three real drivers behind it. One was having no money. So we were number 3 on the most cut councils affected by reduced funding from government grants. So I think there was Liverpool and Tower Hamlets were above us, and then it was Wigan. So quite a large mixed population, but lots of deprivation. So we were quite reliant on government grants. And we had to take a lot of money out very quickly. And we didn't want to just shave little bits off services. We wanted to fundamentally reimagine what our role was working with communities. And exactly what you said, Dean, we found that doing things to people wasn't working. We were getting very poor outcomes. So that was the first motivation behind it. The second one was doing some work with a woman called Hilary Cottam, who I'm not sure if you've all read her amazing book, Radical Help. But I would really recommend it. If you haven't read it, please do. And there's examples from Wigan in there. But basically, we asked Hilary to go and work with 25 families whose children were on the edge of being taken into children's social care. And we tried to work out what we were doing as a system to support them. We were spending between £500,000 and £250,000 per family per year across all agencies. So whether it was the police, social care, whether it was the NHS, mental health services, criminal justice, everyone. And at the end of that year, they were usually in a worse position or the same position as they were at the beginning of the year. So we realised we had to change the way we worked, and we were spending 80% of our time on processing them, passing them through different bits of the system. So we knew that this was a lesson, not just for children's social care, but for all public services in the borough. And then finally, we did a piece of work with an organisation called Nesta. I'm sure you'll have heard of them, Innovation and Creativity in Public Services. And they said very similar things to Hilary Cottam's findings on children's services, but this time for adult social care. And basically, we were spending a huge amount of money and achieving very poor outcomes. And we were doing what we thought people wanted without really listening to them. So those three things together made us realise that we needed to develop a new social contract between citizen and state. And it started in 2011. We didn't go to bed in 2010 with no ideas and suddenly wake up and there was the deal, fully fledged, all created. It took a lot of time. It took, I would say, 3 years for us to start to really feel the impact on the ground. And I'm sure that's what you're finding in your neck of the woods that you can't achieve instant results with this kind of different way of working. The next thing we did was we used anthropology extensively, and we hired a freelance anthropologist to come in and do some work with our initially frontline adult social care teams, to get them to relate differently to local people and to service users. And not just to try and squeeze their needs into the very narrow menu of options that we could prescribe for adult social care. And we got them to really listen and to really think differently about what their role was as public servants. And everyone was trained in ethnography and anthropological techniques. Even the bin men and women, we got them to really look out for signs and things when they're emptying the bins, look for properties that look like they've been neglected, look out for people who look like they're struggling a bit. So every single public servant, whatever their job, whether they were a midwife, a police officer, a traffic control person, was trained in ethnographic techniques, and we called it the deal training. We didn't call it ethnographic techniques. And we basically invested 500 million in the local community. 13 million in 500 new projects in the local community over a 5-year period. And they weren't things that we'd commissioned centrally. They were very local projects that were basically the ideas came from the community, very grassroots, neighbourhood focused projects with a focus and an emphasis on prevention. So there were things like men's walking football groups. There were things like, rather than calling it a dementia support project, we called it a rugby memories group. So it wasn't stigmatised, and it was there to kind of remind people of some of the old players, some of the old games. We funded singing groups for people with chronic obstructive pulmonary disease. We funded all sorts of social activities to try to prevent loneliness and social isolation. We gave away assets. We gave away lots of the council's assets. So we gave away swimming pools, football pitches, parks and open spaces, not just giving them away in a random way, but working with friends groups, working with neighbourhood groups to try to get the best out of that asset and to support the people to do it in a much more flexible and nimble way. So the swimming pool, the first ever one we did, there was lots of worry about, we can't just give a swimming pool to a swimming club. But within a few months, they were making a profit. It was a social enterprise where we'd made a loss for about 10 years because they knew the local community, they knew how to market it to schools, and they knew how to get people in through the doors. So it was a big leap of faith, really, Dean. It was a kind of getting councillors to trust the community, getting NHS managers to trust the community and to work differently with them. It was a whole system endeavour, and a huge amount of it was about culture change, culture shift within frontline teams. So rather than them being just hermetically sealed professionals coming into work and they didn't have a connection to the community, we gave them days where they could volunteer in the local community, paid, to build the connections and the bridges between local citizens and professionals. There are some people, I don't know if you've read the work of Cormac Russell, who don't think that public servants should be involved in local communities in quite that way. They think we should back off. I disagree. 80% of the council's workforce live in the area. They are citizens as well as ambassadors for the place. So we felt it was really important that our staff were part of the journey, and we did something called the Be Wigan Experience, which was an organisational development or a system development immersive experience for everyone who worked in the place, and it was hosted by frontline staff. So I would say about 75% of the deal is OD. It's getting people to rethink how you do your job and how you listen to people, and really applying that deep listening rather than just putting people into little boxes of need. Integrated place-based teams were really important for us. We used risk stratification to highlight people who needed our support before they actually needed it. And we had populations of between 30 to 50,000 in an integrated neighbourhood team where public servants would work together around the family, risk stratify the population, work out who was likely to have a fall, who was likely to have a non-elective admission. And within a year of doing that, proactively reaching out through primary care networks, we managed to reduce unplanned admission by 30% in a year. By adding additional money into the community projects that we did, we managed to add an additional, this is what the King's Fund were really impressed with when they did the report on Wigan, an additional 7 years of healthy life expectancy in the most deprived wards, which was phenomenal. We weren't expecting that. But the single outcome that we focused on was years of healthy life. We wanted to target specific wards and improve that those years of healthy life. So that's what I'm kind of doing at the moment, helping integrated care systems up and down the country to do that. NHS England support me to do that because they think that they like the Wigan Deal model, and they think it could be replicated in other ICSs. So that's how we did it. Sorry, it's a really long answer, that, Dean.
No, it's really interesting, and in doing that, so some of our reflections, certain communities. I've just about what you said about Cormac Russell, and I've met Cormac a couple of times, and I get it is very much around public service, step back. It's around communities doing for themselves. Some of our experiences very much around certain communities need more support initially, more investment to get them to a level to then take things on. How did you deal with that differential investment? You tend to have an inverse care law that says the people who can navigate the health system best get the most from it and sort of get the most benefit, and the people who tend to have less ability to navigate that system tend to access it later and don't get necessarily the best from it. And we need to try and almost turn that on its head in terms of where we invest to get most benefit. Is that part of the journey you went on? Was that quite a difficult task?
Definitely. And when we looked at say, for example, the distribution of GP practices, in the poorer areas, there were fewer. We tried to look at where community centres were, and again, in the areas with higher levels of deprivation, there weren't that social infrastructure, social and physical infrastructure wasn't as good. There's no fresh food shops in some parts of the borough. There was no free cash machines on a couple of streets. It was ones that you had to pay £1 to get 10 quid out. It's that kind of infrastructure that you need to look at and kind of try to, and I think that genuinely is levelling up. It's whatever you think of the announcements that are coming out, it really is a deep analysis of what's actually there, what the local assets are. And then we used an asset-based approach where we looked at the strengths in an area. And sometimes one of the areas we worked in was a place called Plattbridge, which all it really had was a primary school and a Betfred and a McDonald's. But when we went to speak to the McDonald's franchisee, he had been in care. He was passionate about young people and providing something for young people. So we worked with him to set up a youth club. So it's that kind of thing that you've got to work with what you've got and go with the grain of what community activity is there. Not take it over and dominate it, but support it and nurture it and fund it and believe in it. And I think too often regeneration, I spent my whole life doing regeneration projects. I'm very old, and most of them concentrate on physical things. So they concentrate on new road. If we build a new road, people will be able to get to work in this town, and that's not quite how it works. So I think a focus on people, a focus on connectivity and skills, and trying to make sure that we do have genuine leveled up communities. And we don't just go in when there's money and then come back out again. It's about an ongoing relationship with the community and voluntary sector, which is based on trust. It's based on, we trust you, you are an equal partner. One of the things we did was, this sounds a bit controversial, but we didn't have any monitoring. So the 500 new projects, we didn't monitor them. We trusted people to deliver the outcomes, and we got so much more back because that relationship shifted from one of paternalistic parent-child to actually, we're in this together. And I remember the councillors in that meeting where we approved that way of working said, you can't do all this. They'll run away with the money. And being honest, out of 500, 2 did, only 2. But 498 didn't, and worked incredibly hard to make that money go as far as it could. No way could the public sector have ever done that. So I think it's got to be horses for courses, really, Dean.
And is it that same leap of faith? I mean, you talked around the time, didn't you? So started taking, I think you said 3 years till you started seeing sort of impacts from that. And I guess what I hear a lot is we'll do prevention tomorrow, but right now we need to manage sort of the here and now. So public health prevention, yeah, we get it, it's important. Eventually we'll shift the money, and if we don't do stuff now, people will continue to enter that population who are at greater risk more and more, and we can't cope as it is. So it's sort of the wrong way of looking at it, because that's ill health building up, but equally it costs so much more in terms of the public purse. So how did you manage to get that buy-in for that time lag and that belief?
Yeah, we had some really fantastic elected members and some brave leadership there. So we decided to set aside some money, even though we had no money. We set up a transformation reserve, and we would only invest it in prevention. And we asked the community what we should spend that money on. We also realised because of the work we'd done with Hillary, we had so many pointless processes, assessing people, repeatedly assessing them and referring them and sending them to another bit of the system. And we just stopped that. I remember having this conversation when Ofsted came in to inspect us for children's services, and they said, you've streamlined everything, you've made it much more person-centred, and it's much more about the whole family. So for example, have you come across an organisation called PAUSE, Dean? PAUSE, PAUSE. Yeah.
Yes,
Do you work with them in Derbyshire?
Yeah, we do. Yeah.
So this was a bit of an eye-opener for those that haven't heard of PAUSE. So we were spending a huge amount of money on out-of-borough placements for babies and children who'd been removed from parents who'd had repeated babies and children removed from them over the years. And we found we had 800 children fostered or adopted within 3 years from, I think it was around maybe less than that, 500 women. And what we were doing was we were processing the child through the system, through the adoption and fostering system, but we were completely ignoring the women, completely ignoring them. And they would go and have another child because they were grieving for the child that had just been removed from them previously. So with PAUSE, the charity, it's very much a focus, and it costs, I think, about 40,000. That's all it cost in a year to support the charity, to have outreach people, to support the women to develop skills and confidence, to get them, to support them to leave abusive relationships. It's that kind of thinking upstream. Don't just deal with the symptom and the presenting issue. Think about the reason why we're in this position and go back upstream. And someone once said, we've got to stop just repairing the fence. We've got to start painting some creosote on it so it stops breaking. And that's very much the approach we took. And we found that we managed to make all the savings, so all the financial savings. We were spending so much on those pointless processes, on layer upon layer of management, where what we found was that frontline teams wanted to be empowered to do the best that they could for citizens, and they didn't need all these bureaucracies that we'd just created because we thought that was safe. It actually made things a lot worse, and a lot worse for the citizen and for the frontline member of staff. So we were voted like the best council to work for because of all the work we did on untangling bureaucracy and believing in people and backing people and encouraging people to be courageous at work, because we work in quite a high risk environment, don't we, and quite risk averse at times, particularly in health and care. But we often know instinctively what's the right thing to do to support someone. So having those different conversations with people was how we did it, again, based on ethnography.
That is amazing. And I guess in terms of what would you say are the key things that you've learned so far from all that experience?
Trust the community, believe in the community, empower staff to work differently with citizens. I remember a personal story. I remember when my mum was Chair Bolton FT. I remember when my mum came out of that organisation 5 years ago. 22 different people came up her drive on one day. None of them kind of focused on the support she had in place. All of it was about different bits of it that were going wrong, and that's what we've got to change. We need a much more flexible approach to the workforce, which is person-centred, which actually, builds a rapport, builds a relationship, and can support people, particularly I think the first 1,000 days of life and the last 1,000 days of life, if you as a partnership can get a better pathway there, I think that is really incredibly important for integrated care systems.
It's really helpful. We do tend to look at people as a knee and a hip and a heart, and don't we, rather than the whole person.
Yeah, I remember once someone saying to me, "Oh, it's the kidney in Bay 3."
Oh, yeah. In terms of us, then it's a lot then, and I've read quite a bit of the stuff the King's Fund work, and I've heard you talk a number of times, and you talk a lot around different conversations with citizens. Can you tell us a bit more about what you mean by that, and how we might look to progress that, learning from your experience locally?
Yeah, thanks, Dean. So basically, the different we developed something called the Different Conversations Toolkit. I mean, you can get it if you want to. It's all we put all the stuff online for free, so people can just take it. And I think it's referenced in the King's Fund report. But it's basically stop just assuming that people want the most expensive thing that you can provide. Actually, sit and listen and work out what the person's saying to you. So it started in adult social care, where we thought, the best thing for everyone who had mobility problems, who lived on their own, was a minibus to be taken to a day centre, and that was the most expensive package of support we could get. So around about £3,000 a week for that. We didn't actually ask people, is that what you want? Is this what you actually like? What do you enjoy doing? Let's think about the assets and your strengths. And we got social workers to do quiet observation in an ethnographic way, and they'd go into a room and they'd see pictures of grandchildren, they'd see tapestries, they'd see books on, and they'd get a conversation. That's a different conversation. It's about what you like as a person, what do you enjoy doing, and how can I help to make that happen for you every single day. Not there with your clipboard saying, how far can you walk to that? Can you walk to that kettle? What can you not do? Really trying to build a different relationship. That's what it was all about. And some people don't like it, I'll be honest, Dean. Some people like the comfort of the clipboard because it gives them the security and the separation between them as a person. So it can be quite culturally difficult to embed in some teams where there isn't that willingness to work in this different way. But we got such great buy-in from GPs. The primary care networks were really chomping at the bit to get on board with it. Some people, it just comes naturally, doesn't it, to them, and they just want to do it and want to work in that way. Can I be really honest with you as well? This sounds horrible. There were some people who just did not like it and just did not think it would ever work, and were very cynical and sceptical about it. So we gave them a choice, and we said, look, this is the way we're going. If you don't want to be part of this, we will help you leave Wigan with dignity. I think there is quite a hard element to this as well, that if you want to carry on putting people into boxes of need, and you want to carry on having that paternalistic relationship with residents and patients, then it's not the place for you. And that's where, when we had to make savings, we focused a lot on values and behaviours. So being positive, being accountable, and being courageous, they were our 3 values. And if people didn't really want to be part of that, we would support them to leave. And that's partly how we made the savings. So rather than just everyone putting their hand up for voluntary redundancy, because I don't think it's not very strategic, that is it really. You might get lots of people going in one area who you don't want to leave. We based it all on values, and really embedded those values through the OD work that we did. So every one-to-one, we didn't call it, this is your one-to-one, every 2 weeks with your line manager. It was called My Time, and it was asset-based conversations, so different conversations between line manager and direct report, because we found that if that doesn't work, generally the person isn't happy at work. So it's focusing on that, building that rapport and that strong relationship between managers and direct reports. And the first question on the My Time was, how are you? How are you doing? How are you in yourself? How's everything going? Rather than, where are you up to with that project? So if you see what I mean, it's turned on its head. It's a human to human conversation, really, the deal.
And that's removing some of that clipboard stuff as well, isn't it? Whereas like you want to sometimes in one-to-ones that have been placed before with supervisions where it's like, got to actually these things, I've got 45 minutes, boom, 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 and then move on so you're coping all right, and then off. But that I guess is an equivalent of seeing people as a certain thing. Like you are only a job when people are a whole person with family and outside things to work, in the same way that I see people as a knee or a hip. When you see people as a whole person in every part of the life, that really resonates with me. When you've talked about this and you've talked about system and Wigan, in terms of the deal, did it start in the council and then move beyond that setting, or was it always a partner? Right.
Yeah, so it started in the council. It started in adult social care, where we had a huge overspend every year. It was like 8 million, 16 million, 21 million. And the previous director of adult social care said it's a structural problem. But it wasn't. It was actually what we were spending our money on was the wrong stuff. So we got a new director, a guy called Stuart Chorley, who I'd really encourage you to, if you don't know him, I'd really encourage you to invite him to one of your sessions. He's brilliant. He's still there. He's still at Wigan. And he had some great ideas and he really championed and led this change. But what we found out very soon after was that it was equally applicable to children's social care. So it started off really within adults. It very quickly spread to environment, to policy. Policy and transformation really drove it. And then we got interest from primary schools and schools. We got lots of children were really interested in it. There's a real strong emphasis on recycling. And you get children going on recycling and they love it. So the head teachers really loved it. We had a deal for business. So the local Heinz, every tin of beans you've ever eaten in your life is made in Wigan. And so we got Heinz involved in it. We had almost like a community wealth building approach to the local businesses. So they would employ local people. They would do local supply chains. They would work with us on public health messaging. So that kind of everybody who sets foot in the place is part of this deal. It's not just the council. Being really honest, the NHS, the primary care, the GPs were so keen on it, but the CCG weren't initially, until they asked me to run the CCG as well as the council, and suddenly they became great converts to it. But they were very much commissioning needs to be done centrally. You can't trust the community. They'll run away with the money. We know what's best for people. But over time, not everyone thought that, but over time it shifted. And that very grassroots commissioning, prevention, emphasis on prevention, that customer journey mapping, let's find out why this happened in the first place, risk stratification, they were very, very keen on it. And so the hospital again were quite slow, but again, changing leadership. This is the thing, if you just get one fired up person in an organisation who really believes in this stuff, they can move mountains. But it is quite, I had to get used to people looking at me as if I was mad for a couple of years in meetings with the CCG and the Acute Trust. Mental health got it, but not a lot of other people did it. And I think it was just forming what I called a rebel alliance of leaders in the system who were really passionate about this and who you could rely on and who you could, set up a WhatsApp group to, plot how you were going to take over, infect the NHS with wellness. That was our mission, really.
Oh, this is just this is really great stuff. I'm in awe at the minute. I admit. So, just thinking around when you talk then around, sometimes I think we have. I'm guilty as this is others. This view of we know best. Have you got tips that could help us show in how we show humility when we're engaging with populations and we're making them know that they are heard and they're being listened to? So I think sometimes we do consultations and we get whatever responses, but I don't think we ever really engage and consult in a way that we want to be ourselves in many things. I just wonder if you've got any tips for us from your experience in that regard.
Yeah, I think if you as a partnership know what you want to do and you're going to do it anyway, I think people get fed up and they can tell when they're just it's just a paper exercise. I think it's got to be genuine listening, genuine consultation, genuinely asking what people think, and then changing what you're going to do as a result of it. And if not, telling people why you've not. But I always think that it's got to be that hard data and intelligence that you use to shape services, but also that soft intelligence that you get from qualitative research. And that's, everyone is a researcher. Everyone out there, every single public servant who works in your job, in your partnership, is a researcher. And so it's using the expertise of frontline teams to tell you what's going wrong with services. Very often commissioners design things in a darkened room. I do think things are changing. I do like that Bob Dylan song at the beginning. I really do think things are changing. And I think with ICSs, I helped to write the guidance, and I was really impressed with the way it wasn't like a bog standard set of NHS guidance. It was very much, this is reliant on the maturity of your system. And so, yeah, I think don't do it if you're not serious about doing it. And if you are serious about doing it, train everyone to do it every day, not just as a one-off exercise.
And so within the ICS, what would be your view on the role of place in that setting?
It's essential, absolutely essential. And, I think boards don't spend enough time on neighbourhoods and on place and on the fine-grained data that we get from individual places. So for me, it starts on the street level. It starts with neighbours. It starts with super output areas. We've just done some amazing work at Bolton with one of our community midwives, Ben Ash, and we asked her, we had a sudden spike in stillbirths, all from one particular ward. And we got her to go out and speak to the community and listen to the community and find out what was going on. And we found that it was we didn't know this, amongst a certain group of Somalian women who had a kind of suspicion and fear of going to a GP before 3 months pregnancy. And so we got her to work with them to kind of do some kind of education with them and conversations with them, not in a patronising way, but in a listening way, trying to understand what their fears were. And then we put in place a community support hub in that ward. But without that local neighbourhood knowledge and intelligence and data, we would have just treated everyone the same. And it's like you said at the beginning, Dean, if you're just treat everyone the same, then there will be some who are more able to access those services than others who might have language issues, confidence issues, who might be poor, who might not have the means to actually get to certain things, or to buy good food. So I think that neighbourhood dimension is essential. I think secondly, that bigger neighbourhood, which is where I think we should get public servants to work together around with multi-agency, multidisciplinary teams around the family, a little bit like we did with Hillary. And that's got to go beyond health and care. I think that's got to involve the police, housing, other organisations. And then finally, I think at the ICS level, there's some big decisions we need to take around the provision of services, improving centres of specialism, and focusing on those. We did Healthier Together in Greater Manchester, and I've still got the knife wounds in my back from that. It was really difficult to get anyone to stop doing anything in their area. They all wanted everything to be done in there. So I think it is tough, this stuff, because it involves making decisions that are not always in your organisation's best interest, but they've got to be. I think bringing it back to the citizen, bringing it back to the place is the only way we can do ICSs properly.
And within all that, and involving the citizen, do you think that co-production has a central role in that?
Yeah, I think it's got to be genuine co-production is brilliant to see, where you take your lanyard off. You don't go in there with a set assumption of what you've got to achieve, but you go in there with a listening ear, and at times you do step back, as Cormac said, but that ultimately you change as a result. And you might. I think we do waste still. I sound a bit right wing when I say this. I'm not at all. But I think we waste a lot of money on doing crazy things. So my friend is disabled. You've probably seen her on Twitter if you're on Twitter. Oh, by the way, if you follow me on Twitter, I'm at Prof Donna Hall. I'll follow you straight back. Bit of a plug. But she's great. If you are on Twitter, if you follow at Anna Severite, and she works for Social Care Future. She's absolutely brilliant, but she's disabled. And she said, I'm sick of being offered a befriending service by my local council. I don't want a befriending service, I want friends. It's that kind of thing that we set up as a project because we think that's a good idea. And then when we actually listen to people like Anna, it's not at all. So I think every single thing we did at the start of the deal, we looked at through the co-produced perspective. So rather than it just being a little project, everything should be co-produced. Every single thing, whether it's a stroke pathway, whether it's mental health support, whether it's sexual health support. So we had a brilliant sexual health contract that we put out, which was co-designed with young people. Every single thing that we were doing before, they said stop, it's rubbish. We had alcohol support services designed by people struggling with alcohol, who just said, again, I just think that what you're doing there is ridiculous, totally patronising, I will never use it. So, I think this, for the treasurers who might be on the call, this is a refreshing chance to just, let's do what works, not what we think works.
Excellent. And if we're thinking a bit more about a system in Derby and Derbyshire, how do you think we can help communities in Derby and Derbyshire flourish? If there's 3 or 4 things that we could sort of prioritise, but what would you recommend to us?
I think creating a fund to work differently with the local community, it doesn't have to be the millions that we put in, but creating some kind of community initiatives, prevention type projects across the system, that you can get all the great ideas from local people to do. That would be the first thing. Second thing is I would spend, as you are doing, as a team, on ditching the egos, trying to, because it is really difficult. We've been trained, haven't we, to be very pro our organisation, not pro the system. And it's quite countercultural to do things for the system that don't necessarily benefit your own organisation. We've got to change the way boards work. So spend as much time and then more on system leadership, and building your strengths as a team, building trust and the strong relationships that you've got as a team between you. And then finally, I think it's that OD piece with all of your staff who work in the partnership in Derby and Derbyshire. Believe in them, trust them to get out there and empower them to work differently with citizens and have that prevention focus. I think those are the 3 things.
That's really helpful, thanks. In terms, I'm just thinking through, just back a step, we mentioned before around the integrated care system legislation. How do you think health and wellbeing boards can play into that and their role? Because if you look at the white paper a certain way, the ICP is almost written in certain instances exactly the same as what the health and wellbeing board role is. So I'll just be interested in the reflections you've got around that.
I know it's a complex one, isn't it? I'll be honest, I'm not a great fan of governance structures. I just think the main thing is that we actually get out and do things. And I'll be honest, all the health and wellbeing boards I've been involved in the last 10 years haven't really actually had an action element to them. Public health teams do, obviously, and partnerships do, but I think we've got to streamline the number of meetings we have some way. But the main thing is that we have a clear strategy and an action plan. So the good thing about the deal is I left 3 years ago now, but the deal has outlived me. It wasn't a plan for a person or a leader. And what you tend to find, I've been doing some work with Liverpool City Council, and Birmingham City Council, and both actually. Birmingham have had, in 7 years, they've had 7 chief execs in Birmingham. And in 7 years, 7 chief execs, 7 new corporate strategies. So that's no good, really, is it, for the place?
No.
So, what we need is constancy of purpose. And that's what the King's Fund said about the Wigan Deal. It was clarity. It was simple. It wasn't complicated. People in this country have an average reading age of 8 years of age. And yet we make complex strategy that no one understands. We don't understand it. Our staff don't understand it. So how the hell can citizens understand it? So keep it really simple. We had this thing, plan on a page. So every single plan was on one page. And then, so they said, clarity of purpose, the King's Fund, that was what made it different, and then constancy of purpose. So we stuck with it, and they will stick with it for the next 20, 30 years, because that's it works, you know, it genuinely works. Other places have replicated it. Manchester did something called Our Manchester, and again that stuck. And you know, I think it just works, and it just, yeah, give it a go. Call it something yours, but it sounds like you've got the principles of it already there.
Yeah, I think it's that clarity and consistency. So I think sometimes we get into too many, we end up with too many priorities, and when you got lots of priorities, really they're all a priority, so nothing is it? And sometimes it feels a bit like there's a council plan, council priorities, a public health plan, public health priorities, integrated care system plan, those priorities, and sometimes you can feel like you're being pushed, you're trying to service their many different masters, and really they're all from a different lens, I think, trying to do the same thing, so try and get around the outcome, and we're trying to make steps in that direction, but sometimes it does get a little bit frustrating if I'm honest. Yeah.
No, I can see it entirely what you mean, but you know, I think strategy, very often we make it far too complex. There's, as you say, overlapping, competing strategies, and there's no kind of golden thread tying it all together. At least with this, it was a reference point for everyone to go back to, and that's, you know, I remember once being in a public meeting, we had have your say sessions constantly pre-COVID. And residents, we did it with staff as well. We had listening into action sessions where we would listen systematically to big groups of staff, me and the leader, and then the hospital chief exec and the CCG, and we would listen to ideas. Sometimes we would say, yeah, that's brilliant, we're going to do it, which people really liked. But the residence sessions, I remember at one point, after this is where I meant about 3 years, I remember someone complaining about something or other, a road or bins or something, a planning permission, and someone said, well, the thing is with the deal, you've got to do your bit as well. It's not just about the council doing everything. And I thought that's really starting to resonate with people. And the other thing that we did, which was very popular, was we froze council tax. So we froze council tax for 8 years. We didn't put it up once. And that meant in that time a difference of around £500 per household per year in Band D. And we thought, you know, we need to help support our citizens through the austerity years, and that's the best way to do it, is to actually avoid them having to keep paying increases in council tax. I also think it's a little bit of a cop-out when public services just raise the tax, hike the tax and pass the cost on to the citizen, when, as I said before, there's loads of stuff we do which is completely ineffective. So really taking a mirror to that before we start asking citizens to pay for it all.
Yeah. So within all that, there's a lot then around the culture, so culture change within organisations, between organisations, workforces, citizens. Even she talked about the reciprocal nature then of the deal, where we do X and then in return Y, and as a result of that we don't have to raise council tax, for example. So what do you think then gets in the way of some of this culture change, and what could we do to try and help us navigate through some of that?
I think fear of trying something new, fear that this is so big, it's so huge. Certainly from leaders, I find that they think, well, I can't, I've not got the time to do it. I'm too busy repairing the fence to creosote it. You know, it's hard, it's difficult. It involves a different type of leadership. It involves somebody to think of themselves as a human leader rather than a heroic leader. And it involves trusting people, where everything that we've been trained to do is to mitigate risk and to avoid taking chances. But I think the biggest risk we face is to not do more of this stuff, because we know that public services are broken. The current model of public services are unsustainable. We know that demand is outstripping supply, and we know that healthy life expectancies for the first time in 40 years is going the wrong way. So if you listen to Michael Marmot, I'm a big fan of Michael Marmot. You know, all of his work points to the fact that we've got to focus on poverty, we've got to focus on prevention and helping people economically as well as just medically. So for me, it's got to be about that person-centred model, not the medicalised model that we've been taught to follow. I think there needs to be more training in when people are being trained to be clinicians. There needs to be more about the human element as well as the physical and the medical element. Yeah, so I think those are the main things that stop egos as well. Egos can get in the way. My hospital's bigger than your hospital.
Yeah. No comment on in relation to what you just said then around public service almost broken demand. Almost we can't keep up with that with resources available, and to a certain extent, if we did, we'd spend all the public money on nothing but health and social care. We have nothing else in terms of public sector. Do you think at some point nationally we'll start to see a shift if more areas are able to do what Wigan has done and take some of this on, and we get more around Greater Manchester devolution? Do you think eventually we'll be able to use that to influence national at all, or do you think right now we're a bit stuck?
Yeah, I mean, I think they are listening, and the fact they've asked me to help them was quite a courageous thing to do. That's quite great of them to do that, and they know that it's unsustainable. I think it's difficult politically, isn't it? There are some people in the Conservative Party who believe in this stuff. So there's a man called Danny Kruger. Don't know if you've seen him, but he's big fan of the Wigan Deal. He's been to Wigan. We gave him egg and chips in a community centre. He's an incredibly posh guy. Yeah, so he gets it and he really understands that this is the way forward. The Labour Party too have got people within the Labour Party who really get it. Lisa Nandy obviously does. She's from Wigan. But I think it needs a cross-party support, and it needs, people in NHSE to really get it. Roger Davidson, who's just left to go to London Ambulance, who's the head of the ICS network, really got it. I think there are a few people who do get it. I just think we're a very centralised country. I think we're probably one of the most centralised states in the whole world, apart from maybe North Korea, but very centralised in terms of policy making. And I think we need to be more federal. And I think that's why ICSs are a step in the right direction. You've got your masters and mistresses of your own destiny. But it's having that Opal 4 kind of command and control. Sometimes I think people like to be in that position where they can tell everyone what to do, but it's not right. I mean, again, Chatham House rules, if that's okay. But we were told a couple of months ago we would have to put tents on our car park to cope with the demand for COVID with Omicron, and we knew it wasn't the right thing to do because we didn't have the staff to staff the tents. But we were told we had to get these tents bought and ready to be put up. It's that kind of centralised nonsense that just costs money and doesn't work.
And on that, do you think, well, I know some of this is political, is how do we get the the powers that be to see beyond the NHS is a treatment service essentially? I mean, the reason, if the rhetoric that public health was moved, is because all the determinants that influence health and well-being at the population level really exist outside the NHS. It's planning, it's housing, it's environment, it's leisure, it's all that stuff that we know about. It's disposable income, it's employment, education. Do you think at some point that there'll be an understanding of that? Because I know the general public, and why would they, don't really get that? You see the NHS, that's health, that's where you go, you get fixed. But unless we do all that other stuff, then the NHS at some point becomes overwhelmed because we can't stop people coming in the front door, and then we can't get them out the back.
Yeah, absolutely. I mean, again, in Bolton, we're funding social care. So through our integrated care partnership, the FT is putting money into social care because we can see the interlinked nature of it. Nationally, I think it's quite hard to do that because it's their job to create rules for us all to follow, isn't it? So I think it would take a very brave NHS leader to stop that way of working. But I think if you look at the German model of health and care, where they've got some of the Scandinavian models where it's very decentralised and very based on supporting people. So even the criminal justice system, I don't know if you've seen the Norwegian criminal justice system where they've got the lowest reoffending rate because it's based on rehabilitation rather than punishment, whereas our criminal justice system is very punishment based. I just think we know from all of the research that going down that route just doesn't work, and it costs more, and the outcomes are not as good. So I think, you know, hopefully we'll get somebody who follows the evidence, and hopefully this levelling up white paper will focus on prevention. But I'm not holding my breath, Dean, I'll be honest.
Yeah. So I guess then bringing it back down into safer territory, bringing it back into locals conscious a time. So I'll finish on this question. So in your view, what key things could we, as public servants in Derby and Derbyshire, all do to begin a culture change that which is what we've talked around, I guess, for the past 50 odd minutes?
I would have sessions where you know, where it's okay to challenge each other, and where, you know, put in your diary 4 sessions for all the leaders to really get to know each other, to really get to trust each other. That's the biggest thing, is trust between leaders in ICSs. And then I think start to think about your overarching strategy. What do you want to achieve? What are the big outcomes you want to focus on? You know, is it healthy life expectancy, or what actually is it? Because very often we're not clear because of these interlocking strategies we've got. You know, just pick, say, 3 things, 3 big outcomes that you want to concentrate on as a partnership, and then relentlessly focus on those. Create some money to invest in them, and create teams to work on them across different organisations that are part of the partnership. Include the community and voluntary sector in that. And then I think finally start to do things, because the deal, as I say, it didn't happen overnight. It was an iterative thing, but start to do things that build a sense of energy and excitement within the partnership, so people can see things are starting to change, and start listening relentlessly again to frontline teams. I know I'm sure you're already doing that, but it's really important.
Right, thank you for that. That's massively appreciated. Thank you very much for taking the time to join us this morning as well.
Oh, no problem, Dean. No, it's been great to see you all, and yeah, good luck with everything.
Thank you. Thanks. We'll keep trying. Cheers.
Take care.
Thank you. Bye.